Greetings from the Indian Journal of Anaesthesia. I, Dr. Rohini Dattatri, will be presenting a guest editorial published in the August 2024 issue of the Indian Journal of Anaesthesia. The editorial is titled Beyond Epidurals, Embracing the Realities of Facial Plane Blocks for Truncal and Chest Wall Analgesia. This editorial is by Doctors Daniel Werry and Vishal Uppal. The authors are from the Department of Anaesthesia, Pain Management and Perioperative Medicine, Dalhousie University, Nova Scotia Health Authority and IWK Health Centre, Halifax, Canada. Dr. Vishal Uppal is the Associate Editor of the Canadian Journal of Anaesthesia. There has been a growing interest in the use of facial plane blocks for the chest wall and truncal analgesia in minimally invasive surgeries as a part of multimodal analgesia, moving away from the gold standard thoracic epidurals. However, do we have concrete evidence supporting the use of facial plane blocks over the gold standard thoracic epidurals? The answer is, we have murkier evidence as of now. There is lack of randomized controlled trials, and there is risk of publication bias. Distinguishing between the various techniques, which are just slight modifications with different names, is confusing. The variability in the dose, volume, the concentration of the local anesthetic use, and indications of the various facial plane block makes comparing studies challenging. Indeed, the thoracic epidurals are associated with side effects, some of which could be serious, although rare. The main interest with the facial plane blocks is their favorable risk profile. However, these facial plane blocks are also not without risk. They are associated with risk of hematoma, liver and bowel injury, peritonitis, and pneumothorax, depending on the anatomical location of the technique. And last, the most important side effect is local anesthetic systemic toxicity. What are the limitations of the facial plane blocks? The facial plane blocks provide incomplete analgesia. This is because the visceral fibers are spared entirely, and a few somatosensory fibers may be missed, as the local anesthetic may not be deposited immediately adjacent to the nerves of interest. Second, they provide inconsistent analgesia. This is because of the complex structure of the fascia and the anatomical variation of the fascia, which impacts the local anesthetic spread. Also, the variable course of the somatic and the sympathetic nerves through the facial planes are responsible for the inconsistent analgesia. What is the evidence for the use of facial plane blocks in midline laparotomies? In order to obtain proper results, the facial plane blocks should always be compared with the gold standard epidural. Studies which have compared thoracic epidurals versus opioid-based analgesia have showed reduced risk of pulmonary complications, reduced time to extubation, reduced delirium, and intensive care unit length of stay with thoracic epidurals as compared to opioid-based analgesia. While comparing epidural versus facial plane blocks for midline laparotomies, the superiority of epidurals has been found to be less evident. The opioid use and the length of stay are shorter in favor of epidurals, but the differences are small with low quality evidence. It is also noted that the pain scores and the quality of recovery with both facial plane blocks as well as epidurals are found to be similar. Continuous facial plane blocks, wherein catheters are inserted, is found to be beneficial, but it is associated with its own challenges and requires additional resources for the insertion and maintenance. So the major advantage of the facial plane block in midline laparotomy is it can be inserted in supine position post-surgery, wherein the access to the patient's back is limited, more so in case of emergency surgeries. So this can be viewed as an argument for improved efficiency over preoperative epidural insertion. Enhanced efficiency is more so for surgically inserted catheters as compared to the ultrasound-guided inserted catheters. But the efficacy is compromised when it is surgically inserted because these catheters often end up in the incorrect fascial planes. So the major benefit for the use of fascial plane blocks in midline laparotomy is when epidurals are contraindicated, as in the patients with coagulopathy or sepsis. But the evidence is still evolving. What is the evidence of fascial plane blocks in chest wall surgeries? The fascial plane blocks have been extensively used in breast, thoracic surgeries as well as to provide analgesia in case of rib fractures. It is commonly compared to paravertebral blocks rather than epidural analgesia. It has been noted that the serratus anterior plane block, when used to provide analgesia, have reduced pain scores, opioid requirements, and post-operative nausea and vomiting compared to the non-block care, and similar outcomes as to those of paravertebral blocks. Erector spiny block has been found to provide non-inferior analgesia compared to paravertebral block in thoracoscopic surgeries. All these fascial plane blocks provide good analgesia but not anesthesia, so may not be useful in awake surgeries. An important use of fascial plane block is to provide analgesia in traumatic rib fractures, wherein coagulopathy would be present or there would be difficulty in positioning these patients of polytrauma. However, it can still be challenging in the presence of subcutaneous emphysema. There could be need for multiple catheters if bilateral rib fractures are present. So this reiterates the role of gold standard thoracic epidurals in providing analgesia in traumatic rib fractures. To conclude, fascial plane blocks play an important role in various settings. A clear understanding of the limitations is essential so that they can be used in appropriate clinical settings for the maximum benefit. There should be analysis of risk versus benefit, incorporating the patient preference while choosing the analgesic technique. Epidural techniques do have numerous pitfalls like difficult insertion, need for significant resources and expertise. However, abandoning epidurals in favor of fascial plane blocks would lead to de-skilling, lack of necessary infrastructure to optimize epidural analgesia, which can be detrimental to our patients in the long run. Thank you.